Oh, I'm not sure why this is just coming here. Oh yeah, it's gone now. So let's do the urinary system today, and I hope nearly half or first part of Wednesday lecture, and second half of the Wednesday and the Friday, we will continue with the muscles of the lower limb and the muscles of the back. The back muscles mean muscles around the spine, like erector spinae. It is not difficult. It is interesting. And then after that, you know, we can say we can complete most of the anatomy, and the rest will be like nervous system. So, you know, we will have plenty of time, like the whole November. I don't think we are going to take the whole November to study the nervous system. So I think I usually take about 8 lectures for for the nervous system, which means, like, let's say if we go like 3 lectures a week, that will be 2 weeks. So maximum 3 weeks is 3 weeks for the nervous system. So let's say that will take 3 weeks out of 4 weeks for November. Then we have to prepare ourselves for the final exam. So final exam, like, there will be only one attempt. And yes, you know, we can negotiate how many topics we are going to take for the exam. But before the exam, from the end of the nervous system lectures, before the exam, what I want to do is I want to do like more apply anatomy lectures. Like, we talk about some clinical scenarios, and then we go back to the anatomy knowledge, so that you know, when you go for the next step, then you have some knowledge about the clinical environment and clinical encounters and the patient scenario. And I hope many of you guys have next plan after the anatomy. I hope you didn't take this anatomy class just for fun. I hope, you know, there is something behind your anatomy class, and I hope you will use this credit. Like, you're going to earn a lot of credits, you know, like in 4 or 5 months, it's 5 credits. That's quite a lot. Like, it's two classes for three credit classes. So it is a lot. So you have to use it, and I want you to progress to next step. And I don't want you to waste this anatomy knowledge or the credits. So let's start urinary system. So, you know, it's near end of the systems. After the urinary system, we only have, what do you say, the nervous system. So might be the second last lecture for the system. Like, so this is when we talk about urinary system, what do we have? Like, we need to talk about the kidneys. So kidneys, sorry. So kidneys, we have 2 kidneys, right and left, as we know. And ureter is the tubular structure, like esophagus. Like esophagus bring the food from the oral cavity down into the stomach. The same thing, ureter, we take the urine from the kidney down into the bladder. It doesn't do anything other than transportation. It is for transport. And bladder, urinary bladder, is for storage, just a reservoir. It is just like a water bottle, and it doesn't secrete, or it doesn't reabsorb anything from the urine from the urinary bladder. So it is the main job of the urinary bladder is for containment. It's just contain. And urethra is the passage from the bladder to the external urinary meatus. So what is the job of the urethra? The last portion, it might be for the transport of the urine, or it might be transport of the semen, like in male. So it is not just the urine transport, it might be transport of the semen in male, yeah? So that is what we are going to talk about, urinary system. And I want you to remember this diagram. This diagram is really important. This diagram is really, really important. Please remember, please remember. What is it showing? It is showing the abdomen. What about the abdomen? Hey, it is behind the peritoneum, guys. Yeah, so what we are seeing is posterior to the peritoneum. It is the retroperitoneal space behind the peritoneum. So if you just open up somebody's abdomen, you are not going to see this. You are the first, if you open somebody's abdomen, the first thing you are going to see is the greater omentum. Yeah, the greater omentum is the double layer of peritoneal, big peritoneal sheath with the fat and blood vessels in it and lymph nodes. That's what you're going to see. Then if you lift up the peritoneum and throw that away, then you are going to see the intestines. Of course, depending on the regions, 9 regions of the abdomen. And but mainly you are going to see the small intestine like everywhere. It is just going everywhere. And then you have to remove it. Just take it away, the small intestine. And now you will see the cecum and ascending colon, which is retroperitoneal structure. And when you throw away the small intestine, and you will have to throw away the large transverse colon, which is running from right to left side, which is full hanging down with the mesocolon. You have to remove it. Then you will see the another peritoneal layer cover. If you have to carefully remove that peritoneal cover, then we see the kidneys. Yes, we have 2 kidneys, right kidney as left kidney. This diagram is really, really important, guys. Whatever you do, you have to take it because you see the aorta, abdominal aorta, which is dividing into right common iliac and left common iliac, and single vessels coming from the front of the aorta, the first, second, and third. Can somebody tell me, please, the branch from the aorta and paired branches? Hey, what is this branch? That's celiac branch, isn't it? The second, what is the second branch? And paired?
Is it superior mesenteric?
Yeah, superior mesenteric, and the number 3 is
inferior
mesenteric. And you remember the 2 paired arteries. What are they from the aorta? I'm listening. We are not going.
It's the ones for the kidney?
Yeah. So what is the name for the kidney artery?
Is it renal?
Renal arteries, they are paired. And the another paired arteries are?
Iliac?
And no, not yet. Iliac is the bifurcation of aorta. Gonadal arteries, isn't it?
Gonad, yeah.
Gonadal arteries, so right gonadal, right testicular arteries, and left testicular artery, or left ovarian artery and right ovarian artery. So this is the abdominal aorta main branches. So if you look at that, the inferior vena cava, which is the combination of right common iliac and left common iliac, which is carrying all the blood from the lower limb, they combine together like the same, like reverse pattern of the aorta to form the inferior vena cava. And into the inferior vena cava, the renal veins directly go back. Like it is quite perpendicular going into the inferior vena cava and left renal vena. And here, what do we need to remember is, because this inferior vena cava is on the right and our aorta is on the left, the left kidney is farther away from the inferior vena cava and right kidney is closer to the inferior vena cava. Just because of that, the left renal vein is much longer and right renal vein is much shorter. And therefore, if we want to do the kidney transplant, if we want to take kidney from another person, we want to use the left kidney because we have a longer renal vein, so that when we transplant that kidney into another recipient patient, then we have a longer renal vein so that we can manipulate a little bit more. Like if we make a mistake, we might have another chance to stitch it. If it is too short, then if we make one single tiny mistake, it is not going to forgive us. So we want a very long renal vein, and therefore that will be the preference for the renal transplant, the left kidney. Of course, if we can only get right kidney, yes, we'll use it. But ideally, we prefer the left kidney for the renal transplant. And if we do the operation to the kidneys, we will not be going from the front, from the tummy, because we have to cross too many structures to go to the kidney, and we'll make the skin incision just in the lumbar region, in the lumbar region. So that's number one. Number one significance of this diagram is like, the left kidney vein, the left renal vein is much longer than the right renal vein. And of course, this aorta, inferior vena cava, has to go through the diaphragm to get into the thoracic cavity. Inferior vena cava, we have to go to the right side of the atrium, right atrium. And I want you to remember the vertebral level of these major vessels perforating through the diaphragm, which is like VOA, Voice of America, like Voice of VOA 8, 10, 12. V, inferior vena cava, which is 8, vertebral level 8. O for esophagus. Esophagus is 10, and aorta is 12 thoracic vertebra. And therefore, look at the difference, the height. Here, the aorta is perforating the diaphragm pretty low, and inferior vena cava is pretty high, because this is the thoracic 8 vertebral level, and this is the thoracic 12 vertebral level. So 4 vertebral level difference. That is the difference. And another thing I want you to take is look at the ureters. Ureters come out from the center of the entrance to the kidneys. That is what we call hilum. So this hilum, hilum, this is not a new word. Yeah, you have seen hilum again and again. So where did we see hilum? The lungs. In the lungs, like all the bronchus and bronchial artery and bronchial vein going into the lung substance. That area is called hilum. And then lymph nodes like a little kidney shape, bean shape. The lymph node, the afferent lymphatics will go into the cortex, and efferent lymphatics will leave the lymphatics from the hilum. And now you are seeing the hilum again. Hilum is the place of the kidney where all the renal artery, renal vein, and the ureter going in and out of the kidney. This region is called hilum, H-I-L-U-M, hilum. And look at the ureter. Ureter is a bit dilated up here. You can see the funnel shaped dilatation up here and become a narrow tubular structure. It passes in front. Hey, look at that. It is going in front of the aorta and inferior vena cava. It is not going from the back of the inferior vena cava. And you can, so if we are not be careful, then we can easily ignore the fact, hey, it is going in front of the arteries. It is not going behind. It is not going behind. And at the same time, they are pretty, perpendicular, like coming from the top to the bottom, pretty straightly downwards. So if you look at the X-rays on the X-rays, ureters are lying at the tip of the transverse processes of the lumbar vertebrae. Hey, so now, like this ureter is lying on the tip of the lumbar 1, lumbar 2, lumbar 3, lumbar 4, might be lumbar 5. The same thing like lumbar 1, 2, 3, 4, might be lumbar 5. Tip of the transverse processes of the vertebra. So now they are very much perpendicular, coming and going into the urinary bladder. And don't forget the relationship with the ureter and the uterus. Yeah, ureter and the uterus. Because when you are doing the operation on the uterus, that is what they usually damage. They damage the ureter. Of course, the cancer inside the female pelvis, around the female, like the ovarian cancer is when it's spread around the ureter, you are going to damage it. You know that. That's, if you do it knowingly, that's fine. But be careful, the relationship between the ureter and urinary bladder and the uterus in female, especially uterus in female. And at the same time, look at the right kidney and left kidney, which is higher? Which is higher, right kidney or left kidney?
The left.
The left, yeah. Why is that? Is it the drawing mistake, or is it like intentionally drawn like that?
Because the liver on the right side.
Yeah, we have a big liver here. So the kidney cannot go up anymore. Here we will have stomach, and the spleen is usually down in the corner, and therefore left kidney has more room to go up. So again, the kidneys, when we were a little baby, like the kidneys are inside the pelvis, but the body torso gradually longer, and the kidneys gradually slide up along the posterior wall. And therefore, if you might have seen, or you might have heard, or at least on the internet, like the kidneys can be in the pelvis for few people. It is rare, but it is what we call congenital pelvic kidneys. So the kidneys, they do not go up like you and me. They do not go up to the upper lumbar region. They just stay in the pelvis. So that is one of the congenital abnormalities. And if we do the renal transplant, we don't bother going back to the kidney region. We put a new kidney in the pelvic region. So the renal transplant patient, they might have a scar on the abdomen in the pelvis. Why? It is renal transplant. We are not going back to the where the original place. Why do we want to do that? It's such a complex area. We find an easy spot for ourselves. So left kidney is higher than the right kidney, and left kidney is higher than the right kidney, and we will have the little triangular pyramidal shaped structures, which is what we call the suprarenal gland above the kidney. Suprarenal gland. So we will have suprarenal glands on each kidneys. So yes, this diagram is really good, and all the urine from the kidney will drain and come into the urinary bladder. This is the male urinary bladder, and this is the female urinary bladder. And finally, the male urethra is a longer one, which is divided into 3 portions. When it is going through the prostate, it is called the prostatic urethra. And when it is going through the muscle, which is pretty short segment, which is called muscular, and the external genitalia, which is what we call spongy urethra. Female urethra, pretty straightforward. The muscle layer is very small, very short. So outside the bladder, short segment, and then through the muscular layer, and now it is become the external urethral meatus. So that's why the male has longer urethra and female have shorter urethra. What is the implication of that? Because that way create more infection in female, because their urinary urethra is really short. So if they are not clean around the tip of the external urethral meatus, infection will jump in. The male, even if they are dirty, the infection will have to go along here. And when doing so, in older male, like they will get prostate here, prostate inflammation, prostatitis. That is one problem with the male, especially when they get older. So this is the kidneys and the urinary bladder, urethra. That's what we are going to talk about today. And what are the functions of the kidney? So what do they do for us? Do they really need these kidneys? Yes, we do. It is for excretion of all the waste products, excretion of all the excessive fluid. You know, like if you drink loads and loads of water, if your kidney is good, your kidneys will pour out urine. That's a good thing. Excessive fluid. If you are going intravenous fluid, and then if the doctor put you too much intravenous fluid, if your kidney is good, you will pee away. If you eat lots of salts, the kidney will kick out all the sodiums you eat. And waste products, all urea, creatinine, so creatinine, urea, these are the protein metabolism, uric acid. So everything will be excreted from the urine. So it is number one function of the kidney is excretory function. And number two is electrolyte and acid-base valence, because it involves with the control of the sodium, potassium, bicarbonate, and reabsorption of hydrogen ion, excretion of the hydrogen ion and sodium. So a lot and lots of the little metabolites being secretion and filtration and reabsorption happening inside our kidney. And therefore, it is important. If we do not have a good kidney, our kidney is not good, then we have accumulation of hydrogen ion. Then if we are keeping too much hydrogen ion, our body will become acidic. The same thing like bicarbonate. If the kidney cannot handle the bicarbonate, and if the kidney is kicking out the bicarb, then we are going to become acidotic. So that's the problem with the renal failure patients. I believe you have seen renal failure patients, dialysis patient. They are not well because they have excessive fluid, they have excessive sodium, their potassium is high because the kidney cannot excrete potassium. They have lots of urea which cannot be excreted through the kidneys. And urea is very itching and irritating for the skin. So their skin is thick and they have to scratch again and again. It's very itchy, urea depositing in the skin. And they are acidotic. And of course, on top of that, kidney has endocrine function because kidney secrete renin, which is something we will have to talk about today or maybe tomorrow, and erythropoietin, erythro mean red cell, erythropoietin, poietic, make it happen, make it produce erythropoietin. So this hormone or enzyme is going to kick the bone marrow to get RBC from the bone marrow. So if we do not have a good kidney, then we will not have erythropoietin. That means that patient looks a little bit pale and a little bit earthy color. So the renal failure patient is not looking good because they cannot produce erythropoietin. So it's just like a clay color. And it will produce the vitamin D. It will play part of the role in the vitamin D as well. So hey guys, if you want to remember, I want you to take these 3 words: excretion, electrolyte, and endocrine for the kidney. So these are the jobs of the kidney, which is really, really important. Look after your kidneys. So if we have a bad kidney, you know, we take everything for granted, like because we have normal organs in our body, and therefore we don't need to care about anything. Like if somebody who is born with the poor kidney, then they are going to face all these problems. It is difficult life. And I hope, you know, you guys know this, and you guys know this area. What do you got? The Easterly Wastewater Treatment Center. So I mean, it is near Vekave. It is just, I think, to the east of the Vekave. It is the water treatment center. And this, I want you to have a look, have a little read about NPDES. You know, that's the Environmental Protection Agency, which is called EPA. So let's say if we flush the bathroom, if we have a bath, if we just put the dish in the washing machine and then clean the dish, all these wastewater, where do they go? Where do they go, and how do we take it back? Like if we do not clean properly, like, you know, we are going to be like a third world country, like, which is water pollution, which is really crazy, isn't it? Because they do not have this technology and knowledge and money to solve this problem. They have no idea about what they are doing. Like we forests, you know, we can easily enjoy our environment because it's clean. So, you know, like if you flush water down the toilet, I mean, where does it go? I mean, I cannot answer that question, because if I answer that, it's not going to be good. That will be a lie. But I hope, you know, I will be able to answer a few little things about our body. If you drink water, what will happen? If you wee, how do you get your wee? So this is the very very first diagram we saw. Like with kidneys, we have seen this: right kidney and left kidneys, right renal vein and left renal vein, and right renal artery and left renal artery. You can see the celiac artery, you can see the superior mesenteric artery, you can see the inferior mesenteric artery. So 2 mesenteric and 1 celiac, they are giving blood supply to the whole, let's say, gastrointestinal tract inside the abdomen. And you can see the suprarenal gland sitting on top of the kidney, and the ureter. Ureter is leaving the kidney. Initially, it is like a funnel shape, like dilated shape, and gradually become tubular structure. It is for the transport of the urine from the kidney into the urinary bladder. Of course, that is what we are going to see in the cadaver: right kidney and left kidney, inferior vena cava and aorta. So the difference between vein and the artery, the vein is flat because the artery has tunica intima media adventitia, loss of tunica intima media. So medial layer is pretty thick for the aorta. Therefore, even when there is no blood inside, it is still pretty much tubular structure. The vein, hey, it will easily collapse. But what we need to appreciate is this left renal vein, which is long and juicy, guys, which is pretty good for the transplant. Like if you want to stitch it back to another artery, we have room to do that. So you know all these structures inside our abdomen. And don't forget, it is these organs are retroperitoneal structure. It is posterior to the peritoneum. Of course, on the right side, ascending colon and cecum, left side, descending colon, they are also retroperitoneal structures. And don't forget, these kidneys, when we were a little baby in mother's womb, we were in the pelvis. With the growth and development, our kidney, we go up from the bottom in the pelvic organ, become the lumbar region organs. So yeah, so This diagram, I believe you have seen this, the body folding, like head end and tail end fold, and from side by side fold. And by doing so, we have two tubular structure, inner tubular structure and outer tubular structure. Outer tubular structure is going to be our torso, body, like thorax and abdomen, and inner tubular structure is going to be intestinal lumen, like intestinal lumen in the inner structure. Look at that. Look at that. The blue color, ectoderm, mesoderm, and endoderm, blue, red, and yellow. The blue is outermost covering our skin, epidermis and dermis, derived from the ectoderm. And the innermost layer, endoderm, is going to be the innermost lining of the gastrointestinal tract. In the way between, it is all mesoderm. Yeah, how easy it is to remember. The outermost covering our skin, epidermis and dermis, is ectoderm. Innermost, inside the inside. Inside the inside means like inside the big tubular structure, which is body, torso, and chest. We have the inside, an inner lumen, which is the gastrointestinal tract, respiratory tract. These inner lumens, they are lined by the endoderm. Yeah, that's the easy bit to remember. The rest is came from the mesoderm. Look at that mesoderm. So the bone is derived from the mesoderm. Muscle derived from the mesoderm. Kidneys derived from the mesoderm. Intestinal wall lumens derived from the mesoderm. A little bit cocky little thing here inside the spinal cord, spinal canal. That is spinal cord, that is derived from the ectoderm. So ectoderm will develop into the brain and the spinal cord. So therefore, ectoderm is for skin and ectoderm is for spinal cord and the brain. So yes, so this is the limb. So outermost layer, limb is a tubular structure, not a tubular structure, rounded structure. Limb is a tubular structure, rounded circular structure. So we will have the outermost covering, which is the ectoderm, 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 outermost covering. And look at that, the rest is bone and muscle. Therefore, we will have mesoderm. We do not have a tube in a small tube in a big tube because it is not a tubular structure. And therefore, we do not have endodermal derivatives in our limbs. Hey, life makes a little bit brighter, isn't it? Because we have more knowledge. So that is, and I just want to remind you, our kidneys, they derive from the mesoderm, and many structures derive from the mesoderm, because ectoderm and endoderm, they are just a little creepy things. They are just covering outside and innermost side. Yeah, so now we start seeing this again and again. And what am I trying to say here is, if you look at the kidneys, so on the left kidney, the upper kidney shape, it is a kidney bean shape. Yeah, kidney beans come from the kidneys, and it is like a bean shape here. So look at it, has the upper pole, superior pole or upper pole, and inferior pole or lower pole, upper pole and lower pole. If you look at the left kidney, its upper pole is at the vertebral level, thoracic vertebral level, 11 or 12. Of course, it's different from the right kidney and left kidney. What about the inferior pole, lower pole? It is from the lumbar 2, lumbar 3 region. So the kidneys, our kidneys will be, let's say right kidney will be extending from thoracic 12 to lumbar 3. The left kidney will be extending from the thoracic 11 to lumbar 2. So let's say about 11 to 3 region. That is the extent of our kidneys. So yes, keep saying, showing you again and again, but we need to move on. So now here we can see I have drawn a line across here, So like inferior through the inferior pole. So inferior mesenteric is pretty much distal to the inferior pole of the left kidney, and it might be at the level of the inferior pole of the right kidney, which might be lumbar vertebra 3, lumbar vertebra 3 level. So that is, we just studying about a lot of gross anatomy. And let's say if we are in the lab, that is what we are going to see. Of course, we see this, we need to have this information, take this information, going into the lab and look at the cadaver. So this is the inferior vena cava, abdominal aorta, right renal vein, because it is going into the inferior vena cava, left renal vein, which is long and going into the inferior vena cava, abdominal aorta, dividing into the right common iliac and left common iliac arteries. And here is the inguinal ligament. I believe you all like the inguinal region, inguinal ligament. Hey, do you guys like inguinal canal anatomy? Is it difficult?
It was interesting.
Yeah, thank you. Yeah, it is interesting. Yes, that's true. It is like layer by layers and then stacking on each other. And then finally, we create this little inguinal canal. We will forget, we have to read it again. We forget, we have to read it again. Then only then, it will stay in your mind. So once the common iliac will give a branch into the pelvis as the internal iliac artery, and the remaining artery is called external iliac artery. This external iliac artery, once it crosses the inguinal ligament, the same artery above the inguinal ligament is external iliac. Then once it has passed underneath the inguinal ligament, once it's get into the groin, distal to the inguinal ligament, the name change into femoral artery. And look at that. I believe this must be the testes, and this must be the spermatic cord running inside the inguinal canal. Okay, so now let's look at the different view. So let's say around this region, around this region. So let's say maybe slightly higher this region, I am going to make a cross section. This is the transverse section, isn't it? This is the transverse section or cross section. Now we can see the kidneys, right kidney, left kidney, renal artery here coming into the kidney, renal vein leaving the kidney, going back into the inferior vena cava. And this is the peritoneal cavity. Oh, it's written here, peritoneal cavity's organ has been removed. And kidneys are the retroperitoneal structure. Inferior vena cava, abdominal aorta, they are the retroperitoneal structure. And look at the relationship. Relationship is renal vein is anterior and renal artery is posterior. Hey, so that is a good. So I hope you can keep it as a photographic memory in your brain, because many anatomy knowledge, you have to take it, swallow it. Like, hey, this name, why do we call kidney? I don't know. So the same thing, like, abdominal aorta. Why do you give this aorta? Oh, yeah. So it's interesting, isn't it? But the name has been given, and we have to remember. Like, I have to remember Misha. I have to remember Valeria. The same thing, like, I have to remember the kidney. I have to remember the vertebra. So these are the retroperitoneal structures. So if some of the anatomy, you have to keep it as a photographic memory, and then things will gradually build up, and then your photographic memory going to make sense. And if we see that, if we see this slide, we can see the cross section of the CT scan as well. Yeah. So what is the big difference? What are the big difference? Hey, no, there is no big deal about this CT scan. Yeah, because you know that you have the if you have this knowledge, you know this. So that is not a big difference at all. You can see the left kidney here. You can see the right kidney here. You can see the renal vein and renal artery here. So because this is the very much circular rounded structure, so this must be aorta. This is a flat, little bit flat structure. It is more on the right side. So this must be inferior vena cava. This is vein. We all know that the vein is on the right and aorta is on the left. So what is it? Why is it so difficult? It is not difficult at all. Look at that. The inferior vena cava is flat and aorta is rounded, and rounded aorta is more on the left, and flattened vein is more on the right. And they are going into the renal hilum, into the right kidney and left kidney. We can see the vertebra. We can, hey, I'm going to make a what do you call that? Question out of this CT scan. Now, if I haven't done it, I will make a question out of this CT scan, and I want you to know this as a radiologist. This is the liver. We all know that on the right side, we have liver. On the left, spleen, we can see it. You can see the small intestine here. So that is the knowledge we get from this diagram, going to the, because your next step is going into the clinical environment, and then you have to know these structures. So that is pretty simple and easy for you guys now. So look at that again, the same thing. Yeah, look at that again, the same thing. Okay, so now we are doing the cross section, and if we look from the back, so if the patient is in anatomical position, and we are standing behind the patient, and then we are looking from the back. So the left kidney and right kidney, left kidney, and they are below the 12th rib. Hey, look at that. So if there is any step injury, if there is any step injury to the back, and if it is around the 12th rib, we have to appreciate that patient can get a step injury to the kidneys. Hey, so don't ignore that. And don't forget our lungs. Our lungs get close to the 12th rib as well. I hope you remember. And therefore, we have to appreciate any step wound around the 12th rib. They can damage the lungs and the pleura, or the kidneys, or the ureter. So that's the knowledge. We need to have a good anatomy knowledge if we want to walk with the human body. So the same thing, look at that. The kidneys are here, and the lungs stop here at the rib, let's say about 10th rib here, but the pleura extend down to the 12th rib. So if there is any penetrating wound in this area in the back, we have to appreciate the structures underlying, and we have to check the kidney, we have to check the lungs. Okay, I talked too much about this, surface markings and gross anatomy. So let's go a little bit deep into the kidneys. So these are the dimensions of the kidneys. And it is easy to remember, guys. AP diameter is 3 centimeters. The width of the kidney is 6 centimeters. And the vertical height of the kidney is 12 centimeters. So 3, 6, 12, easy to remember. As we try to remember everything in life, everything in life is 3. So that's what we try to remember. Everything in life is 3. So for the kidneys, it is 3. So the thickness of the kidney is 3 centimeters. The width of the kidney is 6 centimeters, and the height of the kidney is 12 centimeters. So this is the side of the kidney. And if you look at that, kidney, like adrenal gland, like the lymph nodes, like the thymus, they will have cortex and medulla. Yeah, the cortex, the outer cortex and inner medulla. Oh, look at that. Look at that, what a wonderful one. Yeah, so the outer cortex and inner medulla, and this, all the structures in and out of the kidney is called renal hilum. Yeah, renal hilum. And look at the ureter, U-R-E-T-E-R, ureter, which is pretty wide because it is going to collect all the urines the kidney produce, and then it will become the ureter, U-R-E-T-E-R. So and this dilated portion of the ureter is called renal pelvis area. And the artery and vein going in and out of the kidneys, and then they will, inside the kidney, they will branch and branch and branch, and then finally small little arteries going in the renal cortex. You can look at that. This is archy, you really arch, like a dome arch, and therefore I might say, these arteries are arcade or arcuate arteries. So let's have a look. So this is the renal hilum. This is the renal hilum. Don't forget that. We have seen hilum for the lymph nodes. We have seen hilum for the lungs, yeah, where the main bronchus, main bronchial artery, bronchial vein, everything leaving in and out of the lungs. That is the hilum of the lung. This is the hilum of the kidney. And let's have a look here. Let's have a look at the junction of the cortex and medulla. So it is good to name corticomedullary junction. Oh, it's written here, guys. It's written here, corticomedullary junction. The corticomedullary junction means outer cortex and inner medulla. That's junction, corticomedullary junction. So let's have a look at the corticomedullary junction a little bit more. Yeah, so we talk about that. We talk about that. We look very carefully and we follow the arteries. So now I believe you all know this slide, size and size of the kidney. We said it is a retroperitoneal organ extending from T11, 12 to lumbar 3 vertebra. Right kidney is lower than left kidney. The size of the kidney is 3, 6, 12. It has got cortex and medulla. So the kidneys, they are surrounded by the fibrous capsule. And then inside the fibrous capsule, we have the perirenal fat capsule. Inside that, we have renal fascia and perirenal fat. So in other words, the kidney, it is so precious. We have to pack with one layer after another, so that if there is any shake in the body, like if somebody falling from the height or jumping down, the kidney needs to absorb the impact. Therefore, the kidneys have, like the outside the kidney, it has a fatty tissue around the kidney. That is what we call pararenal fat around the kidney, the fat around the kidney, pararenal fat. That fat is contained in a fascia. That fascia is outside covered with another fatty layer capsule, and then there is another layer of fat, fascia. So kidney is really, well, to some extent, we have to well protect it. So I hope this diagram is so too easy for you guys. So what is this? This is the dialysis machine. They are really big, isn't it? This is the man-created human kidney. That's a joke, isn't it? Comparing to our kidneys we have, this machine we created is just a joke, which is such a big thing. How can we keep this machine in our abdomen? No way. Yeah. So the God-given kidney is so precious. Look after it. Look after it. So yes, these are the dialysis machines. If our kidney is not functioning well, we need to get help with these machines just to filter out all these three functions as excretive function, electrolyte and acid base, and the endocrine function. Of course, these machine doesn't have endocrine function. We have to inject the erythropoietin into the patient. So it is big, but it is not as efficient as the kidneys. Right. So this is the kidney. What I was saying is we want to see this corticomedullary junction. Can we see that? Hey. Okay, yes, I want to see it soon. Oh. So look at that. This is a simplification of the kidneys. Yeah, outer cortex, inner medulla. And you can see the pyramidal structure or triangular structure in the kidneys, in the medulla. So these triangular or pyramidal, they are called renal pyramids. And the renal pyramids will finally drain into the little collection bank. These are called minor calyxes. And these minor calyxes will combine together to form the major calyxes. And finally, major calyxes will drain into the renal pelvis and going into the ureter. So that was what I was saying. This is outer cortex. Hey, outer cortex here. This is the inner medulla here. Inner medulla, inner medulla is filled with the triangular shape or pyramidal shape renal pyramids. These are the renal pyramids. These renal pyramids will create and make urine, and then finally collect urine in the minor calyxes. And then finally, these minor calyxes will collect and then drain into the major calyxes. And major calyxes will drain into the renal pelvis, and then finally we drain into the ureter. Yeah, so that's the we drain into the ureter. So that is the pretty good arrangement, and which is a highly efficient structures which we are lucky enough to get two in our body. All right, guys, so I'm going to stop here for a while. It is like 11 o'clock-ish. So it is 10:57. So if we take about 15 minutes break, go out, have drink, coffee, tea, water, have a walk, and please come back 11:15, please. 11:15, yeah?
Okay, thank you.
Okay. All right, guys. I hope everyone is back. Not many people this morning attending the class. Hey, you know that in spring, we are coming back to campus. Like for the lectures, we will be online. So one day, once a week, online lecture, and twice a week, the campus lab. So that is great, isn't it?
Yeah, that is good.
Yeah, that is good. So that will be in spring. So I hope, lab will be more engaging, and because there will be no more, that will be difficult for some students who do not attend the class.
Is it true that the school is requiring people to be vaccinated to come back to campus?
Well, I believe they have options. Like, yes, they would appreciate vaccination, but as far as I understand, they will not force you. So if the student doesn't want to vaccinate, let's say they have to do the COVID swab. Like it's pretty annoying thing. Like a few days before coming to this college or that sort of stuff. But in detail, so it is on the website.
Yeah. Okay.
Yeah. So let's say if you have to come 3 times a week, and if you are not vaccinated, and if you go and do a swab like twice a week, sticking into the nose, I don't know. Well, I think it's good to get vaccinated. So job done, give your immune system, train your immune system just particularly for the COVID. Like, I think when we talk about the immune system, we have like general immune system and specific immune, isn't it? General defense and specific defense. So this is for specific defense, like GS particularly for COVID, and this is it, bang. So yes, kidneys, outer cortex, inner medulla. Inner medulla, we have the renal pyramids. And renal pyramids, these are the structures of renal pyramids, like, triangular shape, renal, inside the renal medulla. Yes, outside renal cortex, inside renal medulla. Inside the renal medullas, we have the renal pyramids. So these are the renal pyramids. So renal pyramids, if you look at the triangular structure, it will open here as the papilla of the pyramid. Look at that, papilla of the pyramids. And these are the papilla of the pyramids, Where do they open, guys? Yes, it will open into the minor calyx. Yeah, of course, in plural, it is calyxes. It is in singular term, it is calyx, minor calyx. And these minor calyx will gradually join into major calyx. We gradually join into major calyx, and major calyx will finally join to form the what do you call that? Major calyx into the renal pelvis, and renal pelvis will gradually become ureter. Yeah, and you can see the artery and vein here. So that's what I want to show you. Outer cortex, inner medulla, and inside the medulla, we have the triangular or pyramidal structures, which are called renal pyramids, and renal pyramids will become renal papilla at the tip, and the tip will open into the minor calyx, and minor calyx will open into the major calyx, and major calyx will finally join together to form the renal pelvis, and renal pelvis is a big triangular collecting structure, and finally we proceed as the ureter. Ureter. Okay, so now we have the pyramids here. What are the structures dividing the pyramid? That is what we call renal column. Look at that. Renal column is the portion of the renal cortex coming into the renal medulla. Look at that. That is so simple structure, isn't it? So renal cortex here will come and invaginate into the renal medulla, and that is what we call renal column. Because renal columns coming into the medulla, we form the renal pyramids. Yes, renal pyramids will open as a renal papilla into the minor calyx. Okay, kidney lobes, pyramids, press the surrounding cortical tissue, which is the renal column. So the pyramid and the column is called pyramid, and the surrounding cortical tissue is called renal lobes. So there are about 5 to 10 lobes in each kidney. So let's say this sort of lobes. So this is renal pyramids and the renal column as a lobe, 1 lobe, 2 lobe, 3 lobe, 4 lobe, 5, 6, 7. So in total, there will be about 5 to 11 renal lobes in each kidney. And kidney has cortex and medulla. Cortex extend into the medulla as renal columns. We saw that. And medulla, they consist of renal pyramids, which is separated, and they are striated because of the collecting tubules. So collecting tubule is the structure of the kidney, which we will have to study a little bit more detail. But at the moment, I want you to remember the renal cortex invade into the medulla and dividing the medulla into renal pyramids, and renal pyramids are striated like a skeletal muscle striation because of the collecting tubules. Yeah. And terminology: renal pelvis, renal sinus, major calyx, minor calyx, and apex of the pyramids open into the renal calyx. That's what you have seen. Okay, so look at the arteries. So whenever we can get an organ in our hand, what we should do is we will trace the artery. What is the blood supply of an artery? What is the blood supply of an artery? So look at that renal artery. Look, where is renal artery? Yeah, look at the renal artery coming into the hilum. Look at the renal artery coming into the hilum. And it's separate into the different artery. That is what we call segmental artery. So that is number 2, guys. So the first artery coming into the kidney is renal artery. Renal artery will branch and divide to form the segmental artery. Look at that. Segmental artery will continue as the interlobar artery. Look at that, the artery running into the renal lobe. What is a renal lobe? Renal lobe is a pyramid plus the dividing tissue. So this must be the interlobar artery. Where is it? Interlobar artery. Interlobar artery finally carve like an arcade. That is called arcuate artery. And this arcuate artery will finally spread into the cortex. Look at that. And that is what we call the cortical radiate arteries, because it is extending into the cortex, and it is like a radiation, like spreading there. So that is what we call the cortical radiate artery. So our job as an anatomy class is to remember These tiny little things. These, and yes, after the class, yes, we can forget about everything. So let's try to remember renal artery. We divide into different segments. So segmented artery, and then run in between the lobes, interlobar artery, and then finally carve arcuate artery, and finally radiate into the cortex, cortical radial artery. So this is the segmented artery, interlobar artery, arcuate artery, and radiate artery, radiant artery. So just like a radiation. So the vein, of course, the veins usually follow the arteries, and renal artery and renal vein. And the nerve supply for the renal is from the renal plexus. So renal plexus supply the, it is an autonomic nervous system, and then that we supply the kidney. So once we got an organ, we have to trace the arterial supply and venous supply. Now we know it already. So look at that. So renal artery and renal vein. Renal artery, we divide into segmented artery. Segmented artery, look at the segmented artery. We run in between the lobe, interlobar artery, then calf, arcuate artery, and finally going into the cortex as a radiation, like a radiate artery, arcuate artery. Of course, you know, from the aorta, the blood from the aorta came to the renal artery, then came to the segmental artery, then into the lobar artery, interlobar artery, then became arcuate artery, then became cortical radiate artery, and finally these will become arterial and capillaries, will come into the renal glomerulus. So we have to study the nephron, which is the functional unit of the kidney. We have to study which is the functional unit of the kidney, and then finally, you know, the arterial will become capillaries, then capillaries from the arterial end will become capillaries from the venous end, and finally, you know, they have one extra in the vein. That is what they call peritubular capillaries, and then finally they will become cortical radiate vein. So then now it will follow the artery again. The name are identical to the vein arteries as well. So arcuate artery, cortical radiate artery, cortical radiate vein, arcuate artery, arcuate vein, interlobar artery, interlobar vein. There is no segmental vein. There is only renal vein, and then finally go back into the inferior vena cava. So coming into the kidney, go into the glomerulus, and leaving the kidney, and then go out into the inferior vena cava. So yes, this is the nephron. So nephron, N-E-P-H-R-O-N, nephron is the functional unit of the kidney. What is nephron? So I want you to say nephron is the functional unit of the kidney. So what are the other functional units do you know? Of course, you know sarcomere. Yeah, sarcomere is the skeletal muscle functional unit. Do you know anything else? Neuron. You know neuron. Neuron is the functional unit of the nervous system. Do you know anything more? Yes. Osteon, O-S-T-E-O-N, osteon. So nephron, osteon, sarcomere, neuron, these are the functional units. So nephron is the functional unit of the kidney. Osteon, O-S-T-E-O-N, as a reminder, is functional unit of the bone. And sarcomere is the functional unit of the skeletal muscle, and neuron is the functional unit of the nervous system. So yes, I mean, you know, the nephron, yes, the cortical artery, afferent arteriole will come in, finally become glomerular capillaries. This is the glomerulus. And this is the tubular structure of the nephron. So inside the glomerulus, the renal afferent arteriole came in as a capillary, glomerular capillary, and leave the nephron, glomerular capsule as a efferent arteriole. So the artery will come in, go back out as an efferent, leaving glomerular arteriole, and finally became peritubular artery. Look at that, around the tube, therefore tubular artery, and finally we drain into the cortical radiate vein. So look at that, that is what we were talking about. Afferent arteriole, glomerular arteriole, became the glomerular capillaries, and then finally leave as efferent arteriole, and then become the peritubular capillaries, and finally we drain into cortical radiate vein or arcuate vein, and then finally interlobar vein and renal vein. Okay, so that is the nephron. I want you to remember that. One is for glomerular filtration, two is for tubular reabsorption. So from the blood here, the blood will come with the artery, become the glomerulus, filter, number one, filter into the glomerulus, with the filtrate will come along the tube, and some of the filtrate will be reabsorbed, some will be excreted, and some will be secreted from the vein into the tubule. So that is the exchange here. So these are the three jobs of the renal nephrons. Yeah, number one, filtration, number two, reabsorption, and number three, secretion. So they every like little electrolytes and acid and chloride and bicarb, and they will be exchanged in this way. So that is a nephron. So we need to study about the nephron, and this nephron is the functional unit of the kidney. And hey, nephron from the arteriole come in, become the capillary inside the glomerulus, and therefore we will call it glomerular capillary, and leaving the glomerulus become efferent arteriole, and going close to the renal tubule, there is what we call peritubular capillary, and finally we leave as a cortical radiate vein. Okay, so nephron is a functional unit or structural unit of the kidney. Kidney is nothing more than the nephron, isn't it? So the main basic unit of nephron, kidney is nephron, because nephron is without nephron, the kidney is meaningless. So therefore, we need to study about the nephron. Nephron has renal corpuscle and renal tubule. What is that? So renal corpuscle and renal tubule. So look at that. So this is the renal corpuscle. Renal corpuscle is composed of this capillary and the glomerular capsule. So renal corpuscle and renal tubules. Renal corpuscle is made of glomerular capillaries and glomerular capsule, which is also called Bowman's capsule. Hey, go back and look at that again. So this is the nephron, afferent arteriole. Our afferent arteriole came into the socket of the nephron, which is what we call glomerular capsule, and leave the glomerular capsule as a efferent arteriole. So the combination of glomerular capsule and the capillary is called renal corpuscle. So renal tubule is this one. Yeah, so this is the renal tubule. Renal tubule is made of loop of Henle, collecting duct, proximal convoluted tubule, and distal convoluted tubule. So you might feel like, hey, it's quite a lot, but no, it's something we take it. Yeah, we take it and we look at the next slide. We look at the next slide. Just bear with that. Now you know the nephron, and this nephron we can divide into two portions, renal corpuscle and renal tubule. Renal corpuscle and renal tubule makes the nephron. Renal corpuscle is made of glomerular capillary and glomerular capsule. Renal tubule has 4 different portions: proximal convoluted tubule, loop of Henle, distal convoluted tubule, and collecting duct. And to make it easy, hey, for filtration, it's 1 liter per minute. That is such a big amount of filtration in our body. So let's look at what am I talking about. Look at here. This is the glomerular capsule or Bowman's capsule with the renal capillaries, with the renal capillaries. So renal capillaries just invaginate into the Bowman capsule. And that is what we call the renal corpuscle. And the renal corpuscle gradually leads to become a tubular structure, which is what we call proximal convoluted tubule to start with. And then loop of Henle, U-shape, loop of Henle. And then distal convoluted tubule. And finally, distal convoluted tubule will drain into the collecting duct. Hey, look at that. Look at that. So yeah, now you can appreciate the glomerular capillary push into the Bowman's capsule or glomerular capsule, and then that will lead into the proximal convoluted tubule, loop of Henle, distal convoluted tubule, and collecting duct. So yes, that is the closer look of the glomerular corpuscle. As I say, renal corpuscle is made of Bowman's capsule and glomerular capillaries. So Bowman's capsule and glomerular capillaries. So this is the capillaries and this is the Bowman capsule. Look at the way it is structured. So the way, look at carefully. This is a very rough diagram. Bowman's capsule, look at that here. This is the Bowman's capsule, which is very diagrammatic. But actually, it is like that. This fold of capillaries being pushed into the Bowman's capsule. And Bowman's capsule has here, this glomerula has outer parietal layer of Bowman capsule. And it is inner visceral layer. Look at the two structures. I'm going to go back again. This afferent arteriole became capillaries and came inside the Bowman's capsule or glomerular capsule and lived as a efferent arteriole. And if you look at the structure of the Bowman's capsule carefully, that is what it is. Here outside 2 layers, where the capillaries invaginated only 1 layer, visceral layer. So I want you to remember this anatomy. This other tubular structure has 2 layers, inner visceral and outer parietal layer of the Bowman's capsule. But where the capillaries meet, there is only visceral layer, which is the cells are made of podocytes. The parietal layer is made of the squamous epithelium. So now I'm going to show you another slide. Hey, this is the glomerular capsule, which is also called the Bowman's capsule, glomerular capsule, which is like the parietal layer is thin and it is made of squamous epithelium. Look at that, it's made of squamous epithelium. This is the parietal layer, and the visceral layer is made of podocyte. Look at that. You remember podocyte? We saw podocyte in the capillaries, isn't it? Around the capillaries, like capillaries has endothelial cell and podocytes around. So that's sort of podocyte here. So, and now that is the connection between the epithelial, capillary endothelial cell, the basement membrane, and the podocyte. So now this is the new anatomy which we need to remember. That is the capillary junction of the nephron. And on this side, I believe we will have blood. And on this side, on the podocyte side, we will have the what do you call, the urine. Yeah, so this is the filtration unit of the glomerulus. Yeah, glomerular filtration unit. So let's keep looking up here. Let's keep looking up here. And this is the capillaries, which this is the capillaries, which is the fenestrated type. And now you can see this type of capillary is present in the kidney or small intestine. Look at the kidney or small intestine. So capillaries, how many capillaries, different type of capillaries do you remember? I can say 3, isn't it? I know you know that. 3 types of capillaries you remember. They are, number 1, continuous capillaries. Number 2, fenestrated capillaries, which is this one. And number 3, sinusoidal capillaries, which is used in the spleen or liver or bone marrow. So this is the fenestrated capillary. This is the fenestrated capillary, and that is present in the renal glomerulus. Oh my wow, that is so good. So look at the detailed anatomy. Let's try to understand the detailed anatomy of the glomerulus. So we can see the afferent arteriole coming in, and these afferent arteriole will change into glomerular capillaries in the glomerular corpuscle or Bowman's capsule, and leave the capillaries will leave the glomerular corpuscle as the efferent arteriole. Yeah. So this is in and out, inside capillaries. So we can appreciate now the parietal layer, which is made of the simple squamous flat cell epithelium. Now you can see the simple squamous epithelium. Simple glomerular corpuscle, which is glomerular capsule, which is the, what do you call that, Bowman's capsule, which is glomerular corpuscle, which is made of the Bowman's capsule, glomerular corpuscle, and the capillary. So now if you look at the parietal layer here, so you can, visceral layer, parietal layer is flat squamous epithelium. If you look at the visceral layer, you can see the podocytes. You can see the podocytes wrapping around the fenestrated capillaries. Look at that, these fenestrated capillaries of the glomerulus being wrapped around with the podocytes. Look at the podocytes here. One podocyte here, another podocyte here, with it's like an autopath trying to wrap around the capillary. So which means like we have this fenestrated type of capillaries in, we are using the fenestrated type of capillaries in the glomerulus capillary, and these glomerular capillaries are surrounded by the podocyte as the visceral layer, and that is what we are talking about. So this is the capillary, and this is the visceral layer, and this is the parietal layer. Parietal layer is made of simple squamous epithelium. Visceral layer is made of podocyte. Capillaries are fenestrated capillaries. So that is the arrangement. That is the arrangement. And we are talking about this nephron. We are talking about the renal corpuscle. We are talking about the glomerular capillaries, which are made of fenestrated type of capillaries, and the parietal visceral layer is podocyte, and the parietal layer is simple squamous epithelium, which makes the Bowman's capsule. I hope it is not too much, but this anatomy is really, really important. You might forget that after the anatomy class, but when you come to next step, you are going to remember, you are going to know this. So you need to know it now. So these are the podocytes. These are the podocytes and food processes from the podocytes wrapping around the fenestrated capillary. That is what we call the glomerular capillaries with the visceral layer. Right, so visceral layer of glomerular capsule has podocyte, food processes, and there will be filtration slits and filtration membranes. So let's look at what am I talking about here. Now you can see the better. This is the blood side, which is the plasma, and this is the glomerular side, and this is the filtration membrane. Hey, look at that written here, filtration membrane. What is the filtration membrane made of? Capillary endothelium. Of course, we know that this is the blood vessel capillary, so we will have the capillary endothelium. On the opposite side, we have the podocyte. So podocyte here, this is the food process of the podocyte of the glomerular capillary. And in the center, in between, we will have basement membrane. Yeah, basement membrane in between. On the capillary side, we have the wall of the capillary, which is called the endothelium. And on the glomerular side, we have the podocyte and its food processes. So the urine we have is the filtration, ultrafiltrate of the blood, which has been sieved through these layers into the glomerulus, and finally it will go into the proximal convoluted tubule, loop of Henle, distal convoluted tubule, collecting duct, and finally we drain to the renal papilla and minor calyx, major calyx, renal pelvis, and finally into the ureter. I hope this is not too much. So now I'm going to just revise. So yes, these are the podocytes and its food processes, podocytes and its food processes around the capillaries. And this is a reminder, like in and out. One is going this way, the other is going opposite way, in and out, in and out, in and out. In from the aorta, come in as a renal artery, finally divide into segmental artery, and this segmental artery run in between the lobe, which is made of the pyramids, and then in the lobar artery, then finally calf became the arcuate artery, and finally radiate into the cortex, cortical radiant arteries. And cortical radiant artery will give branches into the afferent glomerular arteriole, and finally capillaries, glomerular capillaries inside the Bowman's capsule, and leave the Bowman capsule as efferent glomerular arteriole, and finally we go into perijugular capillaries, vasa recta, cortical radial vein, arcuate vein, interlobar vein, and renal vein. So that is in and out, yeah? So nearly finished, guy, but let me show you one more slide before I let you go, so that when we talk on Wednesday, things will be a little bit easier. So this is what we are talking about. I've been talking about, this corticomedullary junction for a long time, since early this morning. And what do we see in the corticomedullary junction? That is what we see. This is the artery, and this is the arteriole. Arteriole coming into the Bowman's capsule and become capillaries, and leaving the capillaries, Bowman capsule, as the efferent arteriole. And this Bowman capsule has, inside, we have the visceral layer, which is made of podocyte. Outside, we have the parietal layer, which is made of simple squamous epithelium. And that will lead into the proximal convoluted tubule. It is convoluted. And finally, we go down straight as a loop of Henle, U-shape, which is U-shape, loop of Henle in the medulla. And finally, come back again as a distal convoluted tubule. And finally, we drain into the collecting duct. So here, one important thing, here we have the cortex and medulla. So on this artery and vein, arcuate vein is running along these arcuate veins. I believe you know where they are. They are running around here. So these arcuate arteries and veins, they are on the junction of the corticomedullary junction. Then it will spread into the cortex as cortical radiant artery. Cortical radiant artery will give a branch as the efferent arteriole. Yeah, so on one side, we have cortex, on other side, it is inside the medulla. So which means this loop of Henle and part of the collecting ducts, they are inside the medulla, but the glomerulus, Bowman's capsule, glomerular capillaries, proximal convoluted tubule, distal convoluted tubule, and part of the collecting ducts, they are in the cortex. I hope it is not too much. I'm going to stop here. So we will continue on Wednesday with the kidney lecture. Yeah, Rina. Has anyone got any question? Okay then. So if there is no question, please unmute yourself and say goodbye to all your colleagues.
Bye.
I thank
Bye-bye,
you.
bye-bye. See you on Wednesday, guys. Yeah?
Yes.
Okay.